Let me just start with his history before we go to that physical. He is seeing one of our other providers here who referred him to me for Hep C care. He told me that he was diagnosed in the year 2000, and that he has been followed by a local gastroenterologist for years, but has never gotten treatment. And I actually did talk to him even this morning at a follow-up visit, telehealth, and it sounds like he's never really even had an ultrasound. He was not sure how he contracted Hep C, and I wish Greg Peters were on the call because it was almost comical when I was going through risk factors with him. I'll tell you why in a minute, but anyway, he denied IV drug use, needle stick injury, transfusion, transplant, tattoos. I asked him if he had ever had sex with anybody or been exposed to any shared personal items with anybody who could have been infected. And he said, well, I was a hippie in the 60s. So yeah, of course. So anyway, that was his answer, is he might have had sex or shared personal items. But he denied ever doing any IV drugs himself. He did also work as a pipe fitter, said he was exposed to raw sewage, which I thought was a pretty interesting history. Maybe obviously more likely for a hepatitis A type scenario, but it doesn't seem beyond the realm of possibility that it could expose you to other bloodborne pathogens. He told me that he has been told he has cirrhosis, and his fibrosure, as we'll get to in a minute, confirm that. He is a drinker, and he told me, this was another kind of funny thing, as many drinkers do, he differentiates between hard liquor and beer, and he still drinks 6 to 12 beers a day is what he reported to me. But he said he always was very clear that he doesn't drink hard liquor. He did tell me that he quit drinking once for 9 months, and he thinks he could do it again to take medication. But we've had 2 conversations about the importance of quitting drinking for his liver health, period, given that he has cirrhosis. He's not said to me, oh yeah, I can do that, but as far as totally quitting. So I'm not sure what will happen with that. He has currently no health insurance. His income comes from Social Security, but he doesn't have disability, so he doesn't qualify for Medicare, and he makes $50 over the limit to qualify for Medicaid. His comorbidities are AFib, hypertension, GERD, and he either has asthma or COPD. I wasn't able to discern from his chart, but and I didn't ask him, but he has a ProAir MDI on his medication list. And there you can see his other medications, including notably omeprazole, and notably for our situation. The physical that was up at the top there, he to me looks like a drinker. It's sort of florid faces and red nose, and no jaundice, no ascites, no palpable liver. I put he's immune. I must have been working quickly when I clicked, because I don't think he's immune to either Hep A or Hep B, and he's going to come in today to start vaccination series. But I'll have to double check on that. So you can see that he is overweight / obese with a BMI of 30. His labs, his white count, H&H, and platelets were normal. His ProTime, glucose, and his glucose, creatinine, you can see are normal. His ProTime was 11.3, which I think was elevated, but his INR was 1.1, which was in a normal range. His AST was slightly elevated. I don't have what our upper limit of normal is, but probably the high 40s. Bilirubin slightly elevated, 1.4. I don't have a direct Billy. His APRI score 1.033, child Turco-Q 6, and MEL score 7. His iron studies and vitamin D, AFP were all normal. He's HIV negative. He is a genotype 1A and a viral load of 6.5 million on, this was when I checked him in August. And his serum fibrosis marker, their 0.81 had him at a F4 cirrhosis. I've ordered an ultrasound. The trick there is trying to get something that he can pay for. I've completed the case form before his visit today, so he's coming in for his vaccines. I talked to him again about drinking, and his thing is, well, I can quit drinking when I'm taking the medication, but to me, Hep C is only part of his problem since he has the cirrhosis. Then what I made a note of was that his medication choice would be complicated by PPI use. And then I was having a moment of weakness and anxiety when I put out the case, because none of the patients that I've taken care of before and presented have had cirrhosis. None have been really beyond really an F1 or 2. And so I'm just feeling like, I'm out of my league, but I have echo. And so I would appreciate any recommendations on treatment. I apologize. For 1A, I'm assuming Mavorite or Epclusa would be my choices. I didn't look that up when I was preparing the form yesterday and refreshing my memory. But to me also, the story is complicated, number one, by the fact that he doesn't have insurance. And so, it's funny, it wasn't that long ago when this was the case, when we were having a lot of people who it wouldn't get paid for, and we were, because of the Medicaid rules, and we were investigating for them, but I have forgotten what my options are with him, and I'm hoping that there might be one of the pharmaceutical companies that would treat him. And then the wisdom of, I still think treating him, even if he only quits for the period of time quits drinking for the period of time when he's taking the medication, I'm not sure that he'll get back into care for his cirrhosis, given his lack of insurance. But obviously, even if we treat his Hep C and then he goes back to drinking, his liver problems aren't over. And I think, and then the PPI, I think that Epclusa, that might be a problem with Epclusa, but it's sort of a test because I haven't looked it up. So anyway, that's the story. And as always, I'm ready for help.
Thank you so much, Jen. That was an awesome case. And
oh, there's Dr. Peters. Did you hear my story on this guy about his history?
I did. That was. I don't know what that. I'm not sure what that says about me exactly.
No, you always have these interesting.
It's probably not very good.
Patients that make us laugh, and this guy, for me, when I was talking to him, he goes, well, "Of course."
I laugh all day long. All I see are patients that make me laugh. I think it's
beautiful.
Did you say though? Has he tried to get insurance? Does he not qualify for Medicaid? He might.
Right. No, he said I'm $50 over the limit. Welcome to our system.
Wow. Man, that sucks.
Now, obviously, he'll qualify for Medicare, and he's 63 and a half. So he'll qualify for Medicare in a year and a half. So there's that.
Were there any clarifying questions for Jen and the case she just presented? I wanted to ask everyone out there before we jump into any of the recommendations and feedback. Any of the hub members?
Jen, did he tell you what was the occasion for quitting for 9 months previously, quitting drinking?
He did, and now I can't remember what he said. But it was something similar that maybe it was a medication, it was something, but I don't remember. I'm looking for his chart now, but he feels quite, I guess, almost proud of that, because he brings it up like no problem.
Yeah, I'm just wondering if there was some pathway to approach him for, considering a more, not just 9 months, but a more, if there was some angle in his story that.
Yeah, there was. I didn't write it down. I could return to that. That's a cool idea.
Well, Greg, what do you want to say about it?
Greg, oh, should put you on the spot.
You mean what would I do to, like, how would I treat this guy?
Yeah.
Well, I would definitely engage this guy about sobriety. I mean, probably first and foremost, as far as the alcohol goes. I always try to highlight the fact, particularly prior success, the fact that these people have done a good job, even if it's only 9 months of sobriety. It's pointing out the fact that this person did it once and has success being able to do that is just it's really strong. I mean, it's a really powerful motivator for people to really understand that remember the fact that even though you're not doing this now, the fact that you've done this before is good, and that you're not alone doing it this time. I'll help walk with you through this to whatever extent you need me to do. From a medicine standpoint, I think 8 weeks of Mavreet would be good. I don't know how the rules work as far as getting Medicaid. I don't know if this guy could make a charitable donation of $100 and then be $50 underneath the limit. I don't know if it's like, but I sure would do it, man. I sure would tell him to talk to his tax guy and see, because I don't know if it's adjusted gross income or if it's, I don't know if there was some way to do that, but yeah, through the pharmaceutical company, he'd probably be an excellent person to treat. With the PPI, I always like to try to get those people off of it, honestly. Like if they've never even tried, the PPIs are one of those things that you just sort of put somebody on and then everybody forgets to take them off.
I hate them.
Sometimes they try coming off it, they do fine. They certainly do fine for that period of time. So that's what I would do with him.
Mm-hmm.
So from a drug regimen choice, if he had to stay on the PPI, then the logical choice is Navarette. If you could get him off the PPI, you could also, use, a sofosbuvir-based regimen. Since he's not a Medicaid patient, you don't have, you can use Harvoni. You don't have to use Epclusa.
Mm-hmm.
I think that you probably could get the drug pretty easily from one of the patient assistance programs. I think the real trenchant issue here is his drinking.
Yeah.
And you're right that this is a complex patient, and it's complex because of, at an ethical and moral level, we could pretty easily cure this guy in 6 to 12 weeks, right? But if he's only going to stop drinking for 8, I didn't mean 6, I meant 8. If he's only going to stop drinking for 8 to 12 weeks, that isn't going to help his liver a whole lot. And so, and I don't know, I haven't worked with the patient assistant plans in a while. I don't know what their requirements for sobriety are. For Medicaid, right, you'd have to say he was, no, Maxie.
Maxie, I know.
No barking.
Maxie, Medicaid.
You have to say that, he was sober for 3 months, right? But I think the other thing that's a little confusing to me is that although his FiberSure score is in the cirrhotic range. He's got a middling APRI. I don't know if you calculated his FIB4. It's always nice to have as many of these things as you can to, you know, bring to bear on it.
I
If you
did.
look at labs, he sure doesn't look like he's got cirrhosis, right? He's got a normal albumin. He's got pretty normal labs. Got a healthy white and red count. He's got, you know, let's see, where's that stuff? Let me make this smaller and see. So his labs are, yeah, you know.
Nothing terrible.
He's a smoker. He's got lots of hemoglobin. His platelets are 40, which is probably around the lower limit of normal, but not consistent with what you think of as being cirrhosis. His protime and INR are on the money. His albumin is normal. His total Billy is just a little bit up. For the APRI score to be consistent with cirrhosis. Now remember, none of these things are perfect. All of these are all like shot, you know, these are all approximations. You would expect it to be greater than 1.5. You know, I would certainly give him some more vitamin D and try to bring him above in the 50 to 60 range. But if he has cirrhosis, he's got very early stage cirrhosis because his labs are pretty damn good. So I wonder, that's another kind of wrinkle in this case. I wonder where this guy really is. And if that you can't, he doesn't have insurance, it's hard to get more, you know, diagnostic information.
Well,
I
see,
wonder-
he was willing to get the ultrasound if we could get it. I might be able to get it on a sliding scale, and then I thank you on the FIB4. So that's a calculation. I can look that up.
Yeah, I
Okay.
mean, you can just plug his values into
Right.
the, you know, into the equation.
Okay.
But I would like to see, you know, where we're really leaning. Because remember, the fibers, none of these things are like perfect.
Right. Right.
But
Right.
whether, yeah, whether he's got confirmed cirrhosis or not, it really comes back down to, is he going to be a drinker?
Yeah.
And, you know, I always feel uncomfortable in these situations because I feel like I'm not the police, you know, we're not the police, we're the caregivers, you know, we're not the moral, we're not here to, you know, make those kinds of judgments. But the reality is that if he's going to go back to drinking and just quit for a brief period of time, curing his hep C isn't going to do a whole lot for him.
Yeah. Right.
And I just, you know, I mean, that's where I'm more hung up almost than anything else, aside from the fact that I'm not convinced he's got cirrhosis.
He is a smoker, by the way, and his GGT was slightly elevated. It was 77. Upper limit of normal is 65, which is probably the alcohol, I would assume.
Yeah,
But yeah, I just I feel weird about treating him. I mean, it's a very poor use of resources for if he's not going to quit drinking.
This is John here at the hub. I sort of am very comfortable with treating him.
Cool.
Okay.
Despite if he doesn't stop drinking, you know, that's, I guess working in silos is what we do. I don't not treat somebody's endocarditis if they're going to use drugs again, you know, here. So just going off what I see all day, you know, the liver is an organ that can take multiple hits to cause trouble. And if I can reduce one of those by treating him, great. I think he does have significant fibrosis. It's FIB4. Kaylee just calculated at 4.25, whatever. It's high. His APRI is above 1. He's got clinical sequelae with the rosacea face or whatever that sort of suggests, you know, he's got, but I don't want us to think of cirrhosis as something where you tip over and then suddenly you've got this irreversible concept of cirrhosis and there you are. Even on liver biopsies back in the interferon days, people could regress and no longer have cirrhosis after treatment on repeat biopsies back in the days when we used to do repeat biopsies. So this is, you know, the other word for cirrhosis being scar tissue to the point of having functional impairment. And if we can slow that down by treating him, and if he continues to drink, rather than he may remember, if you look at lifespan of compensated cirrhosis, you have 90% survival at 5 years. And, you know, maybe we can delay his decompensation for a couple of years and blah, blah, blah. So my own ethical threshold, I would, I guess it's probably because I'm giving a talk today on when to defer therapy. And the unambiguous answer is don't. But you could hold this out. Kaylee had some ideas about holding it out as a carrot, you know, to get him to stop drinking, and maybe he could get an 8-week course. You know, he does have Child-Pugh A, and remember the FDA warnings on any protease inhibitor containing regimens, including Mavorite, really apply to Child-Pugh B through C. So Mavorite right now he could take if he'll stop drinking. Hopefully he'll stay at an A. And otherwise, yeah, like Dr. Feinberg mentioned, I really like Harvoni for this guy, or Epclusa as well, if we can manage his PPI in some way, shape, or form. And Kaylee and I were just sitting here talking, the most important test in all of our minds is an ultrasound in him, because you need to make sure he doesn't got cancer. And, you know, if he does have really advanced cirrhosis, that's probably going to be troublesome. You may see that morphology. I think Dr. Feinberg's right. If he even has cirrhosis, it's early. It's early. In other words, he just got some scar tissue, and we can treat him. And hopefully, once he's got that one devil off his shoulder, he can get the other one off the other shoulder with alcohol. But that's my thoughts. Any thoughts you have, Kaylee, that's different?
Yeah, I agree wholeheartedly. If we think about kind of our restrictions as far as treatment and when to defer, a lot of it is insurance driven as far as the sobriety requirements. But at the end of the day, we're patient advocates. And so, you know, Dr. Gilby said, if we don't just not treat someone's endocarditis because they have recent drug use. And in this gentleman, you know, my analogy to patients that do actively drink alcohol and have advanced liver fibrosis and have Hep C is that, you know, we can treat your Hep C. I can help with that. The alcohol has really got to be driven by you. It's like walking through a landmine. You know, today could be your last day and you step on a bomb. You know, it could be another month, it could be another year, but all in all, that's really got to be driven by you.
Kaylee, where are you walking around with bombs?
I think I got that analogy from you.
Oh, sorry.
I'm serious. So, but that's my analogy, is that you just don't know with alcohol and advanced liver disease, what is his day of decompensation, when's that going to come? And so that's, that would be my approach with him. You know, I would also caution, you know, with his extent of alcohol history, really, although you're counseling him on sobriety, we have to worry about withdrawals in him. And so he's not somebody that I would encourage to just stop completely at once. He's really going to either have to have some assistance. And I think, Jen, you talked about maybe medication, if it's going to be feasible for him financially, but maybe an Antabuse or Camprol to help with his sobriety, but just really counsel that it's not going to be wise for him to just stop. He probably will be somebody to gradually work down so he doesn't go into withdrawals or have DTs or some terrible thing. But I think, Jen, this is a complicated case, and I really think you did an awesome job presenting him. I mean, you really worked through everything as you were presenting it, all the things that were going through my thought process, you spoke on those. And so I really commend you. And I know kind of the more times you present, the more you get accustomed to this, but you really, you know, I know you want some reassurance, but I'm trying to give it to you because you really did a great job and you really thought through this case very well and asked great questions and really touched on everything I think is appropriate. His, you know, regimen choice, the Epclusa, and Rachel can go into more specifics if she'd like, but I mean, the Epclusa can increase the concentrations of his Eliquis. And so that's something to consider. It's not a contraindication, just make sure, you know, and especially in an alcoholic, you know, you really monitor for signs and symptoms of bleeding. And so we kind of worry about that with many ways. So I would really just not push one way or the other, just lay out the facts. These are my concerns. This is what we could do, and which way does he let him drive? Which way does he want to go? I don't think you'll have any problem getting any of the regimens approved for him through patient assistance. He's got more options than if he had Medicaid.
Okay, interesting.
Yeah.
Actually, Haley, that was a really important, valuable thing that you brought up about the possibility of DTs, because this guy really is a heavy drinker. And despite that he's no longer drinking hard liquor, 12 beers a day is a fair amount of alcohol. So.
And it's likely more than that, I would say.
Yeah, right. So, you know, the possibility of DTs is real in this guy. And I think that was I think that was a really insightful thing to warn Jen about. Yeah, I mean, again, you'll need to assess what he wants to do and what he's willing to do. Mm-hmm. You know, I didn't mean to infer that I was against treating him. It's just that sometimes you just sort of wonder whether you're going to make some real headway with somebody if they can't get their substance use disorder that affects their liver. It'd be a different thing with a different substance use disorder, but he's got one that hurts his liver. That may be more of his liver damage than his hep C is, for all we know. Mm-hmm. So, you know, I think you just have to, do exactly what Kaylee said, talk it out with him and say, these are the directions we could go in, and this is what could happen, but if you continue to drink at this rate, it won't be the end of your problems.
Right. I can also work closely with his PCP, who's a colleague here at New River, who's a really excellent provider, and to have both of us working with him. And I worry that he won't be able to get off that PPI. I mean, I'm like Greg. I talk to everybody about PPIs and try to transition them to H2 blockers, but especially with his drinking, I mean, on a good day, it's hard to get people off a PPI. So it may be that I have to go with Mavret if he wants to. Treat.
I mean, if you could get him down from 40 to 20, then you would have to pay attention to how he times, and he was on a Sabascovir-based regimen, then you would have to pay attention to, his dosing in relationship to the PPI.
Yeah, okay, good.
And that's a possibility too.
Right, good. Yeah, helpful.
Some of these people, they get sober and they don't need their PPIs anymore too. A lot of
so much could go better for him, as we know.
Yeah.
It's super, guys. Thank you so much for all the feedback and interesting conversation.
Yeah, absolutely. We're about halfway through the session time, so I want to leave some time for the didactic as well. But before moving on, I did want to ask Jen, was there any other questions that you wanted to have addressed before we move to the didactic portion?
I don't think so. I want to just make sure if Rachel has anything to weigh in on. I have my notes about the PPI and about the Eliquis if I use Epclusa. I want to see if she had any other concerns about him.
No, looking at his other medications, no major issues. You're going to have that interaction with the Eliquis with pretty much any of the regimens you pick. So either way, you're going to have to warn him and educate him about that increased bleed risk.
Okay.
Like everybody's kind of mentioned, just to echo that, with the omeprazole, you can lower that dose or do a trial run, see if he can hold it for a little bit, when he starts therapy. And then if he says, you know what, this is not working out, I need something, maybe try at a lower dose. Starting that way, or like you said, change it to an H2RA in that instance. And then just to kind of tackle, if you do pursue it with the patient assistance programs, a lot of that information is online. Both the Harvoni and the Epclusa they're both made by Gilead, and that their PAP program is called Support Path.
Okay.
they're entirely online now, and they actually have everything initiated. I just was doing one of these here with one of our social workers here at Ruby. So everything is now initiated by the patient online. So, and they'll want tax documentation and all that. And it's all case by case. As far as I know, they're still not necessarily looking at sobriety restrictions. A lot of it goes around the financials,
Okay.
but it's case by case. So they'll evaluate it that way for the patient. And then Maverick is through AbbVie. That's their support program. Theirs, as far as I know, you could call them, and then if they haven't changed it, and it's been a while on theirs, but you could call them and get that information faxed to you as far as forms and get that all filled out. And those will, if they are approved, those will come directly from their pharmacies. You would have to send them a prescription, essentially like an order, but it'll go straight to the patient from their pharmacies. There's no other pharmacy involved there.
Gotcha. And if I were to offer him antabuse, anything to worry about there with interaction?
With any of these specifically?
With antabuse. If I were to offer him antabuse to help him stop drinking.
Oh, okay. No. You wouldn't have to worry about that with me.
Okay. Hey, thanks a lot, guys.
Awesome. Thank you all so much for those recommendations. And thank you so much, Jen, as well. I echo what Kaylee was saying. That was an awesome case presentation. We appreciate it so much. All right, so we will move on to the didactic portion. So Dr. Gilfus, I'll pull up your didactic for you. Just let me know when you want me to advance the slides, and I'll...
Thanks, Mitra. Yeah, I just wanted to point out, yeah, you're right. Kaylee's making fun of my really fancy background on my slide, by the way. So sorry. And I wanted to, Greg, you made the best point of the day. I think it's so funny when people take heartburn medicines when they drink, because it's basically, you know, if they're drinking Mike's Hard Lemonade, it's like drinking stomach acid. So I don't know. There's so, but anyway, so I'm going to talk about when treatment is deferred. And so my source is hcvguidelines.org, and I went to that, and they have a section on it. By the way, that, for those who aren't frequently on this call, hcvguidelines.org is really, it's an amazing updated, or it's a routinely updated website that's sort of our go-to to answer most questions about treatments, even just care of patients with hepatitis C. And I mean, it's fun to go there after not looking at it for a little while. It's like rewatching a really great movie. It's like when I watched Twilight again. I'm like, that's why I liked it so much. It's great. So,
oh my God, I just threw up in my mouth. I need to take my reflux medicine.
Yeah. So anyway, yeah, it's just like Twilight. HCVguidelines.org, this is the source. If any of you are still respecting me at all, you'll listen to what I'm saying. The punchline of this one is there is a section, and the gist of reading the entire thing is saying, don't do it. It's, Omitra, can you go to the next slide? So worth a trip down memory lane, that in general, we had this triaged approach where we would look at extrahepatic manifestations, degree of liver fibrosis, et cetera, and sort of initially treat people who had what we thought was those with the highest likelihood of benefiting acutely. And we've since moved past that and really to the concept of treat everybody, as long as they aren't going to die from a non-liver related mortality in the next year. So they define that short term now as a year. And Kaylee brought this up to me yesterday. Interestingly enough, they've actually, hcvguidelines.org has started including the words acute and chronic hep C. We should treat all patients with acute and chronic hep C, which is interesting. And certainly be interesting if Medicaid follows suit, but that has made it into their guidance now. Again, except for those who are going to die of other reasons. And next slide, Mitra. Thank you. And the reasoning behind most of the section on when treatment is deferred goes through reasoning why not to defer therapy. And they go through fairly profound cases and studies that have demonstrated the benefit of treatment. So we can certainly prevent progression of liver fibrosis. And as I mentioned, during the case, you can actually have some reversal of some degree of cirrhosis and fibrosis. Decreased morbidity and mortality, of course, that's every doc's goal, but the quality of life improvement is usually the patient's goal. And in other words, people feel better if we treat them. The extrahepatic manifestations, the two most common that we're going to potentially improve in people's lives if we do treat, is diabetes control and cardiovascular risk. There's other more exotic things, you know, the vasculitic syndromes, the cryoglobulinemia, which occurs in 10 to 15% of patients, whether it be symptomatic or asymptomatic, goes away when we treat. The rheumatoid arthritis, like arthritis, would get better in most people. If they were unfortunate enough to get a heme malignancy from chronic B-cell activation, you can have a much better outcome if you go ahead and treat their hep C. And of course, there's this whole treatment as prevention, which we borrowed from the HIV literature, which has started to make its way into hep C. So a lot of reasons we want to treat people. Next slide, please. And I don't want to defer based simply on, you know, the things we had been deferring on. Next slide. But that doesn't mean there aren't cases where we should defer. And I guess one of the things I wanted to do is ask the group situations in which they've deferred therapy. If anyone has any cases they'd like to volunteer, feel free to interrupt or chat in or anything like that. We all had cases where we decide to not go with a treatment on day one. You know, it's a truism in chronic viral infections these days. As our treatments get safer and fancier, we're treating people more quickly. Best example, that's HIV. Now that's a big push to treat on the day of diagnosis. You know, that's the kind of thing. And hep C, I've not heard quite going there yet, but we're sort of pushing that way. But there's still things to make sure we have in a row, all our ducks in a row before a patient gets the prescription. The most important of which is logistical issues. Can the patient comply with treatment? Does the patient have an address whereby we can get the medicine to the patient? Can the patient have a ride to come back to do blood work? Stuff like this are probably the most common things that allow us, or that we delay treatment for, purely life logistical issues. The risk of reinfection I want to redefine that one. Remember, if you're reinfected, there's no biologic plausibility that says you can't be cured again. So really, if these were medicines that cost $10, we wouldn't really worry about the risk of reinfection outside of the fact that it implies ongoing drug use and all the hazards therein. But remember, if I'm treated with Harvoni and I'm cured and I get reinfected with another virus, I could use Harvoni again. It's a new virus, it's a new infection. However, there's the one treatment per lifetime imposed by a lot of payers. And I hope that's artifactual and at some point a historic footnote. But right now we are obligated to at least consider that. Medication interactions, you know, Rachel gave a beautiful didactic on that a couple of months ago. And you obviously the amiodarone and some of our anti-epileptics are ones that are almost absolute contraindications. And please refer to her talk on those. Pregnancy, unfortunately, still is an issue in a patient who is pregnant or planning to get pregnant. There's a current prohibition on using these medications. We all talk about people who are child's pew B or C. We need to be careful with the regimens we choose. And of course, we'd like to co-manage those patients with a hepatologist or a transplant center. And the other stuff up there. But again, if anybody in the on the chat or would like to sort of talk about reasons that they have deferred treatments, or no comment, we can talk about it later.
Oh, I said I can.
Oh, never mind. Kaylee wants to comment.
I'll comment.
Oh, okay.
I just don't want to interrupt you. No, this, I just wanted to put in like a little tidbit just on the slide as far as the risk for reinfection and counseling our patients. You know, even in our patients that would have a history of injection drug use or intranasal drug use and they have a relapse, remember, I mean, we can still counsel them on ways to reduce hep C reinfection. So just, you know, in the event of a relapse, if they can utilize a needle exchange, just make sure not to share their works. I mean, they can still be responsible even in the event if they do relapse in the future. So that's part of my counseling process with them. And then one thing that I try to do is give them the option too. These are patients that are kind of more recent in their sobriety, I give them the option, you know, if they feel like treating their Hep C now will help with their recovery progress, we can go ahead and start treating them. However, if they want to work on their sobriety a little bit longer to hold themselves accountable, we can work on that also. Because again, that restriction becomes a lot from payers. So a lot of times it's that 90 days, sometimes 3 to 6 months sobriety period. But once they meet their insurance criteria, I kind of let the patient take the reins on when they want to start treatment if they don't have any concerns for fibrosis. And that kind of gives them a little bit more, feeling more empowered in their care too.
Super good points. Thank you. Yeah. I guess I was just thinking too, I don't have it up here, but per the discretion of transplant referral center too, could be a reason to defer therapy. I know we've talked about sometimes being on a transplant list, they
legal.
Like, legal troubles,
Yeah,
going to jail.
Make sure that if they have any kind of outstanding charges or pending legal charges, you know, you might want to defer until those are closed, because if they start treatment and go to jail or prison in the meantime, they're going to have that interruption and it could impact their retreatment as well.
By far the most common reason I don't treat people right away is logistics. They don't have an address that I can reach them, a telephone I can reach them, or they're, you know, homeless and they're not sure when the next time they're going to come in, or I have no faith that they can reliably take medications on a daily basis. And that's not a judgment. I ask them, I'm like, do you think you could manage taking medicines on a daily basis? And if they say no, you know, it's problematic. Next slide, please. And so really, what do we do if we can't treat people? We just take care of them as best we can, which, you know, it kind of goes through this. I'm going to go through each one of these. So next slide, please. We want to just remember that a patient like today is a high-risk patient to defer therapy on, because they were probably infected in the 1960s, and they don't have decades or to go before they decompensate. But if you met somebody who had a recent diagnosis and you assessed their risk factors as truly having been recent in the last 5 to 10 years, there's very often not a gigantic risk of having advanced liver disease. By the way, there's some exceptions to that, and I'll talk about those in a couple slides. But we always like to educate. Next slide, please. And obviously, commenting on ways to prevent transmission. Kaylee talked about ways to use drugs more safely if we do decide to not treat that person quickly. And of course, giving them the good news that yes, you can hug and love on your household contacts, just don't share utensils of daily hygiene, especially those that could have blood exposure. If you are dealing with men who have sex with men, you do want to educate on sexual transmission, especially if there's HIV co-infection. And of course, if it's a young woman of childbearing age, you want to educate about the risk of vertical transmission, which again, we quote as fairly low for non-HIV infected, probably around that 5–6%. Next slide, please. And you know, every talk I give, literally every talk I give, I have this stupid slide in here, but it's like my favorite. So it's also probably the only journal I've ever read. No, I'm kidding. But but it basically says that while we focus on the hepatitis, what kills people is the substance use that or whatever behavior it was that led to their initial acquisition. And I credit Dr. Feinberg and Kaylee for always paying really good attention to those. In this particular case, they were really talking about the alcohol being probably the elephant in the room. And we can't forget whatever risk factor it was that led for their acquisition of Hep C is what likely kills people more than the hepatitis itself. Next slide. We just want to keep our labs up to date, and remember the ECHO form that we have is a wonderful reminder of what labs we should follow every once in a while. And we do want to do ongoing screening for co-infections. The co-infections that are usually screened for hepatitis A, B, HIV, and I often include RPR on that, simply because a high-risk behavior often accompanies the risk behavior for hepatitis C, or I should say high-risk sexual behavior often accompanies the other risk factors for Hep C. And then, again, follow our liver fibrosis markers via whatever modality you would like. Again, more of them that you follow, the more likely you are to have a reliable picture. If you have elastography, serum biomarkers, you could follow, of course, your APRI and FIB4 calculations are easy based upon just your lab tests. So next slide, please. And if anybody who has advanced cirrhosis advanced fibrosis of F3 or greater on any modality would benefit potentially from HCC screening. And that can be done with Q6-month ultrasound as the easiest modality. And again, if you've ever had substantial scar tissue on or suggestion thereof in a non-invasive modality, I think this is something we can definitely do. One of the most devastating things to see is HCC. It's a terrible disease, especially if it presents outside of the surgically curable condition. Next slide, please. And we want to vaccinate our patients. Now, I think the COVID stuff has really brought chronic liver disease into light as, it's reinforcing how important our liver is from an innate immune system standpoint. And with chronic liver disease being a risk factor for more severe COVID and poor outcomes, we obviously think lung and heart, but the liver certainly is an important organ immunologically. And we want to protect our patients who have chronic liver disease from routine infections. We want to give them flu shots. We want to make sure they're up to date on tetanus. And of course, hepatitis A and B. The only one up there that might be a little bit of a surprise is the pneumococcal vaccination. So you can imagine there would be people who would not otherwise qualify for a pneumococcal vaccination where their only indication would be chronic liver disease. Next slide. And we, of course, during our visits would want to aggressively look for signs and symptoms of chronic liver disease. So asking about swelling, hemoptysis, melena. We'd want to look for extrahepatic manifestations with a direct review systems questions. So we'd want to look for the joint pains, directly ask about increasing fatigue, and of course, the more significant things like vasculitis, night sweats, weight loss, etc. So we'd want to hunt for the extrahepatic manifestations. Next slide. We'd want to advise our patients to not drink at all. There's been no threshold of safe alcohol consumption, so our advice has to be less is better, none is our true advice. Only if they have severe liver disease do we have to tell them to really avoid NSAIDs when we're worried about GI bleeding. Same with excess acetaminophen. So a lot of times people come in with the concept they can't take any Tylenol. It's not true. They just can't take maximum dosage if you have significant liver disease. And something I'm personally really bad about asking about, and that's herbals and other supplements like that, as Rachel stressed the importance that sometimes you can have important interactions from your herbals. Next slide. Yeah, that's kind of one of the major statements from this section was from HCVguidelines.org. It says, you don't want to defer therapy. And if we do, we want to have ongoing assessment. How often? Next slide, please. Maybe every 6 months. But what we do want to do is make sure that we're paying most attention to patients who have significant fibrosis. Next slide. Fibrosis rates of progression vary depending upon certain factors. Some of them are host factors, some of them are viral factors, some of them are co-infection factors. And we can look at them up there. So fibrosis stage, so fibrosis begets fibrosis. It's sort of, the way to think of it is remember the natural history of hepatitis C. A good percentage of people don't ever get scar tissue, but those that do likely are to get more. The inflammation grade is the activity score on the fibrosis thing, and those who have higher activity scores are the ones who are likely going to get more scar tissue laid down, so get more advanced fibrosis. Being older at time of diagnosis, being male, having immunosuppression. Now the immunosuppression one is fascinating. I'm going to tell you a scary story. I have a patient who had HIV co-infection with lousy CD4 cell counts, and they had within 5 years progressed to F3. And I know exactly when they acquired it because it was a sexual transmission, and we sort of followed the patient routinely. And due to their HIV medications, we were having a hard time finding a drug to treat them with. And also this was back in the time when there were fibrosis restrictions, but they genuinely progressed very rapidly rather than the 20 years that we normally quote people. The immunosuppression, whether it be from chemicals or substances that we're giving them as medications, or if it's some endogenous immunosuppression like HIV, it can really change the rate of fibrosis progression. Drinking, we always mention hepatitis C's impact on diabetes, but diabetes also has an impact on hepatitis C in a negative way, and that probably has to do with insulin resistance and concomitant fatty liver. And then there are viral factors. So I mentioned the co-infection with HIV. Being concomitant infected with Hep B is like another hit to it. And then, of course, having genotype 3 can make fibrosis progress more rapidly. And note this little caveat down below, and they mention this specifically on the hcvguidelines.org. They say, your RNA level, which we are so attuned to paying attention to the viral load for HIV as probably being the most important factor for viral progression and control of disease, transmissibility, et cetera. They make a point on it in the HCV guidelines to mention that even patients with really low viral loads can progress to having advanced fibrosis. Next slide, please. And remember that fibrosis does not always progress linearly. So in those patients who we have comfortably deferred therapy and are sitting there happily at F1 for a couple assessments, as their age progresses and maybe they perhaps get worsened diabetes or get put on an immunosuppressant medicine for a rheumatologic reason, et cetera, that fibrosis can start progressing non-linearly. That's a hard word to say, but you get the idea. It progresses quickly, more quickly than we'd expect. There we go. That's a better way of saying it. Next slide. And let's, I fall prey to this all the time too. I look at FibroSures all day long, and I very often forget to look at the activity score. And especially if it's somebody who we've decided to defer therapy, paying attention to their activity scores, important, prognosticating who's going to progress more rapidly. Next slide. Oh, and by the way, I should mention the activity score, since they mentioned this in the hcvguidelines.org. The cheap surrogate of an activity score are the transaminases, or the AST and ALT. That's sort of a marker of inflammation, your AST and ALT. They make a distinct point of mentioning that even patients who have persistently negative AST and ALT can progress to chronic liver disease and cirrhosis. So that's an important fact. We don't want to be comforted falsely by normal transaminases and therefore defer therapy just based on that. And of course, as I mentioned, the extrahepatic manifestation that we want to look for, we want to remember that those are unrelated to the fibrosis scores. So in other words, you can have a patient with a normal fibrosis F1, F0, and they can, from the chronic immunologic stimulation, develop a B-cell lymphoma, or they can have kidney disease, et cetera. So we want to routinely assess that during every one of our office visits. Next slide. And the guidelines try not to be too prescriptive about how often we need to see our patients, and obviously more often for those who have more advanced fibrosis, but they said repeating blood work and keeping an eye on the fibrosis markers about every 6 months seems reasonable. Next slide. Okay, I don't know if I'll have time to do these, and maybe we'll do them next time, because this was just something Kaylee and I were worried we didn't have a case today, so we were going to have a second didactic built in. But Jen, you brought a beautiful case, so thank you. It saved you all from having to listen to me for another 15 minutes, and I guess I should end my talk by saying go Team Edward.
Oh my God!
For anyone who knows what that means.
The Twilight reference, I got that, Dr. Gilfus. Thank you so much. That was awesome. We have about a minute or so left before the session is finished, but were there any questions or comments for Dr. Gilfus?
Or any stories of why you guys deferred therapy that I didn't think about? There's a million valid reasons, I'm sure.
This is open for anyone, even the new folks out there. Please feel free to chime in as well.
We've had a couple of instances where we've kind of delayed treatment until, like, married couples that wanted to get treated at the same, like start their treatment at the same time and kind of sync that sort of stuff up. And they've had either an issue getting, like, they haven't had the same insurance. One might have, I think there's one that was two different commercial insurances at the same time, that sort of stuff. But it,
Yeah, I think you hit pretty much the reasons we've had to defer. I mean, jail and transportation around here. People live a long way from the office and it's hard to get here.
Thank you both for that. Were there any other final comments or thoughts that you'd like to share with the group?
Dr. Rexroder, I would say with your background, there's no roads coming into where you are. Transportation is going to be a major issue.
That happens to be the view from my back porch. I wish I was sitting there.
That's a beautiful background. I love it. All right. Well, we've come to the end of our session, unfortunately. I wanted to thank Jen. Or Jen, was there something you wanted to add as well? I saw you unmuted.
Yeah, that skiing looks like the major mode of transportation where Dr. Rexroad lives. No, and thanks to everybody. It's super helpful.
Absolutely. Thank you so much for that awesome case again. And thank you, Dr. Gilfus, for that didactic, and all of you for joining. Just a couple housekeeping announcements. Our next session will be on October 8th, and Kaylee is going to present on approach to Hep C treatment experience in patients with genotype 1. And maybe Dr. Gilfus can kind of tag team along if there was some other things you wanted to mention from today as well. So